topic is gingival enlargement. Now, the gingival enlargement initially was also termed as gingival hyperplasia. It was also termed as gingival hypertrophy. But then recently the term has been changed and they are calling it as gingival enlargement, because your gingival hypertrophy, when you say it is hypertrophy, it means to say there is an increase in the cell size. And when you're saying hyperplasia, it means to say that there is an increase in the number of cells. But then it can, when you're calling it as gingival enlargement, it can be either of them. Either they can be a hypertrophy or they can be a hyperplasia. So you can't just restrict by saying gingival hypertrophy. Probably there is hyperplasia. Therefore, in order to eliminate this confusion, they have reached to a conclusion that we should reterm it as gingival enlargement. Now, this enlargement can be physiologic or it can be pathologic. Now, let's see the basic classification system based on the etiological factors and the pathologic changes that happen in the classification system that was put forward based on etiological and pathogenic factors or pathologic factors. We can classify your gingival enlargement as inflammatory gingival enlargement. Your inflammatory gingival enlargement can be either acute or chronic, or else drug-induced gingival enlargement. Certain drugs are responsible for causing gingival enlargement, like your antihypertensives, your anti-epileptics, and your immunosuppressants. Apart from that, the next category for your in the classification is the ones gingival enlargement that is associated with systemic diseases and conditions, like your conditioned enlargement and your systemic diseases. The conditioned enlargement includes because of probably some condition like puberty, pregnancy, vitamin C deficiency, or plasma cell gingivitis, or a non-specific conditioned enlargement. Now, the second subcategory under this associated with systemic diseases and conditions is your systemic disease, which is leukemia or any granulomatous diseases like sarcoidosis, Wegener's granulomatosis, all these. And then the next category is your neoplastic kind of gingival enlargement, which can be either benign or malignant, and then your false enlargement. Again, there's another classification based on the location and distribution. Either it can be localized enlargement or it can be a generalized enlargement, and then it can be either just limited to your marginal gingiva, your papillary gingiva, or you can say that it's involving the all parts of the gingiva, that is your diffuse enlargement, which includes your marginal, interdental, and your attached gingiva. You can also categorize your gingival enlargement as discrete, that is either sessile or pedunculated. Now let's go in. How do you assess? Let's go into the slide which is showing how do we assess gingival overgrowth, right? Now, gingival overgrowth or the degree of gingival enlargement can be scored by a scoring system which was given by Bokenkamp, and then he said that you can grade the gingival enlargement as from 0 to 3. So he said if you want to score it as grade 0, then you should have no signs of inflammation or no signs of enlargement. And then he said you can score it as grade 1 if the gingival enlargement is just confined only to your interdental papilla. And then he said you could score it as grade 2 if the enlargement involves your papilla and your marginal gingiva. And then he said you can score it as grade 3 if the enlargement covers 3/4 of your crown surface. Now let's go in detail about your first gingival enlargement, that is your inflammatory gingival enlargement. Under that comes your acute inflammatory gingival enlargement. And under the acute gingival enlargement, your inflammatory gingival enlargement comes your gingival abscess, your periodontal abscess. Okay, now let's see what is your gingival abscess. Your gingival abscess is nothing but a localized, painful, rapidly expanding, sudden onset, limited to marginal and interdental papilla. You know that your abscess is nothing but a localized collection of pus, and when this localized collection of pus limits or it is seen only into the gingiva, it is limited to the gingiva, either involving your marginal gingiva or your interdental gingiva, then it is called as your gingival abscess. It's localized lesion and it is quite painful, and there's a lot of pus that is expressed. The etiology being probably an acute impingement or an acute lodgement of any kind of structure. It can be a toothbrush bristle, or it can be a fish bone, or it can be a speck of an apple, or some any other foreign body which is just implanted into the tissues at an acute cause. How does it appear clinically? Now this appears as a red swelling and then with a smooth shiny surface, okay, and then you can probably see a sinus opening in the most, you can create a sinus opening at the most fluctuant area of the abscess, okay, and then within 24 hours this becomes fluctuant and pointed with a surface orifice. This was I was talking about, okay, and then the tooth becomes sensitive to percussion. Let's see what is the treatment that you should do for a gingival abscess. You have to give, the first thing you should do is to administer local anesthesia. Once you have given a topical or a local anesthetic infiltration, then you have to remove the cause. Okay, suppose there is a fish bone, immediately remove, try to explore where it is and try to remove the cause. And then you do a thorough scaling and root planing and establish a drainage. That is, you try to drain the abscess and remove the microbial deposits. And then following that, in more acute situations, what you can do is you can place an incision on the most fluctuant area of the abscess and try to drain it out through the incision that you have given, okay, or else you can just apply gentle pressure so that the pus can be expressed out of the sulcus. You irrigate it properly with saline or betadine, and then once the bleeding has stopped, the patient is sent back to home, okay, and then you reassess the condition after about 24 hours. If needed, a surgical access is done. What is a periodontal abscess? Now, your periodont, when you say your gingival abscess, I said it's limited only to your gingival structures, right? When you're saying a periodontal abscess, it means to say that the periodontal apparatus is involved in the abscess or in the disease process. So, periodontal abscess can be defined as a lesion with expressed periodontal breakdown occurring during a limited period with easily detectable clinical symptoms and signs with a localized accumulation of pus located within the gingival wall of the periodontal pocket. It represents a period of active periodontal destruction. Remember, it is not the typical sign, but it is just a secondary sign of your periodontal diseases. It means to say that the disease is in a very active stage. So now what is the etiology? There can be 4 etiological reasons for the development of your periodontal abscess. The first reason being the spread or the extension of inflammation or the infection of the periodontal tissues into your deeper pockets, okay? And then the second one can be a lateral extension, your extension of your infection in the periodontal, probably only the epithelium is involved, and then it is spreading laterally into the gingival connective tissue, okay, of the pocket wall. And then, or else the third reason can be formation of the pocket with the tortuous course of the around the root, so probably a spiral pocket. And then the last one can be because of the incomplete removal of calculus during treatment. And you're leaving behind some specks of calculus, some dislodged specks of calculus within the periodontal pocket, and this can act as a foreign body and result in the formation of a periodontal abscess. This is the etiology. Now let's see what are the clinical features of a periodontal abscess. Now it appears around as an ovoid swelling or an elevation of the gingiva along the lateral surface or the lateral aspect of the root. You have the patient could come with a throbbing, radiating kind of a pain. The patient could come with a throbbing, radiating kind of a pain, and he is very much sensitive to even palpation. Yes, he's very much sensitive to palpation, and there can be some kind of a tooth mobility with associated lymphadenopathy and less frequently some systemic effects like fever or malaise. Diagnostic criteria for a periodontal abscess: first, the symptoms revealed by the patient, and then the signs that are found during the examination, which have a pocket depth of greater than or equal to 6 millimeters and presence of bleeding on probing. Apart from that, when you take a radiograph and examine, you will find some pattern of bone loss and absence of any periapical lesions. All these diagnostic criteria will support towards your periodontal abscess. What is the main difference between a periodontal abscess and a periapical abscess? How do you differentiate between a periodontal abscess or a periapical or a pulpal abscess? First thing is, your periodontal abscess is always associated with a pre-existing periodontal pocket, whereas your pulpal abscess does not. It's always associated with a pre-existing carious lesion, right, or a large restoration. And then the second point is, there's always, when you take a radiograph, there might be an evident horizontal or an interdental bone loss, or a furcation involvement, or a periodontal angular type of pattern of bone loss, whereas your pulpal abscess will show if any kind of a pathology in the periapical area, and then it does not show any presence of periodontal pockets. And then the teeth are vital in case of your periodontal abscess, whereas in case of a pulpal abscess, the teeth are non-vital. Apart from that, your periodontal abscess, the swelling is most often present, or it is located, the location of the swelling is restricted to the lateral aspect of the tooth root, whereas for your pulpal abscess, it's mostly limited to your apical, where the apex of the root is located. Approximately there you can find your pulpal abscess. Sometimes there can be a vestibular tenderness or a vestibular obliteration because of the presence of a periodontal because of the presence of your pulpal or a periapical abscess. Sometimes you can have a tracking fistula and a sinus opening also present in case of your pulpal abscess. And then the pain in a periodontal abscess is usually dull pain, and it is localized. You can localize the pain, whereas in a pulpal abscess is very severe and you can't localize the pain, and it's often more difficult to localize it. And then usually your periodontal abscess is sensitive to a lateral percussion, whereas it may or may not be present. It's not a typical feature, whereas your pulpal abscess or a periapical abscess is very much tender on a vertical percussion. This is one of the positive signs that a periapical infection has developed, that this is tender on percussion. Moving on to the treatment of a periodontal abscess. How do you treat it? Firstly, you have to obtain drainage through either the gingival or the pocket sulcus, or by giving an incision on the most fluctuant area of the periodontal abscess. And then you do a thorough scaling and root planing. Probably you have to think of doing a periodontal surgery, because most of the times the patients with a periodontal abscess will have deep periodontal pockets and or probably a furcation involvement. So you have to treat maybe by doing a periodontal surgery in a later stage. And then you have to put the patient on some systemic antibiotics, and sometimes if the bone loss is so progressive that probably you might have to extract the tooth by checking your mobility. And then comes the last acute inflammatory gingival enlargement, maybe because of your pericoronitis. Now, this pericoronitis is an acute infection affecting or refers to the inflammation of the pericoronal flap, which is seen surrounding a partially erupted tooth. Now, you have various types of this pericoronitis. You have an acute, subacute, and a chronic form of pericoronitis, and most frequently this is seen in the mandibular third molar area. What are the clinical features? The tissue around that, or the pericoronal flap, also called as the operculum, will be more red. It is swollen, it's erythematous red, and it is quite tender on even touch. It's extremely painful, and the patient may complain of a radiating pain to the ear. He might even complain of trismus or an inability to open the mouth, and then he can also complain of pain to the ear, the floor of the mouth, or the angle of the jaw. Sometimes even the angle of the jaw can be swollen. Apart from that, the patient can also give a history of foul taste and inability to open and close the jaw. And then when you palpate for the lymph nodes, you can have a tender lymph nodes in the regional lymph nodes. How do you treat pericoronal abscess? First thing that you do is establish drainage. Okay, you need not have to probably give an incision, but at least the minute you lift up the pericoronal flap, you can establish drainage through the space between the pericoronal flap. And then if incision and drainage is needed, you have to do an incision and drainage, especially at the most fluctuant area of the abscess, and supplement the patient with a good dose of antibiotics, probably for about 5 to 7 days. And apart from that, you do a thorough scaling and root planing, and try to relieve of all the debris or the deposits that are collected underneath this flap, and do a thorough warm saline irrigation, which will give a good quick relief in that area. And then this will decrease the amount of the abscess or the inflammation that has happened there. Okay, and then later you can probably think of whether extracting the tooth or whether you have to do a procedure called as operculectomy, depending on the space that is available for the whether the space is adequate for the tooth to erupt or not. Coming or moving on to the second part of the inflammatory enlargement, that is a chronic inflammatory enlargement. We know that the chronic inflammatory enlargement is one of the most common features that you see as a result of gingivitis, right? A chronic gingival inflammation will lead to what is called as chronic gingivitis, and then further leading on to basically the inflammation will cause an enlargement, and this is called as a chronic gingival enlargement. It's one of the most common type of an enlargement, and usually it is a secondary complication of any other type of gingival enlargement. Remember, even if the patient has, if you have identified the patient of having a drug-induced form of gingival enlargement, but this can always be supplemented, or it can always be secondarily infected or secondarily inflamed because of the deposition of the plaque and accumulation of plaque and the inability of the patient to maintain the oral hygiene, therefore leading to a secondary chronic inflammatory enlargement. Right, what would be the etiology? As I told, the main etiology would be accumulation of plaque, dental plaque, or a prolonged exposure to dental plaque, and inability to maintain oral hygiene, or any other areas that are favoring the accumulation of plaque. Now, how does it appear in a histopathological section? Now, there will be exudative and proliferative changes, both happening simultaneously. You have engorged capillaries, you have lots of neutrophils, and then you have preponderance of other inflammatory cells other than your neutrophils, and there is an increase in the intercellular fluid content. Therefore, you can call it as an exudative and increase in the fibrillar content or the collagen fibers. What are the clinical features of chronic gingival enlargement? It can be localized or it can be generalized, involving the entire mouth, and then appears as a ballooning. First, how does it appear? It appears as a ballooning of your interdental papilla, and then it forms a life preserver shaped edges or a bulge. Okay, slowly it progresses and it becomes painless unless it is complicated by a secondary trauma or any kind of infection. Occasionally, it occurs as a discrete sessile or pedunculated mass resembling a tumor, but most of the times it occurs as a diffuse enlargement. How do you treat it? The simple method is, first thing that you should do, the cause is because of the accumulation of plaque and other deposits. So what do? You first remove or eliminate all these deposits by doing a thorough scaling and root planing, and then probably you might have to think of doing a gingivectomy procedure if the enlargement doesn't come down even after the thorough scaling and root planing, and if the fibrotic kind of an enlargement is left behind after the entire edema has come down, then probably you should think of doing a gingivectomy procedure. And then coming to the gingival enlargement in mouth breathers, again this is a form of chronic gingival enlargement. Now this is because of the habitual breathing through the mouth and then instead of the nose, and it's most commonly seen in a very younger individuals for about 5 to 18 years of age, and the habit is resulted because of an altered jaw. Maybe these patients most of the times have typical clinical features of a pigeon face appearance with a short upper lip and a thick lower lip or a hypertrophy of the lower lip. Apart from that, the etiology for this mouth breathing can be because of any block in the nasal passage, so the patient is not able to breathe through the nose, or else it becomes a habit even after the correction of the nasal problem or the nasal obstruction, still the patient continues to breathe through the mouth. So that can also be a reason, or any other upper respiratory tract infections like rhinitis or sinusitis, or any allergy to the airborne infections. So I told the clinical features, the patient will have some pigeon face, a short or a flaccid upper lip, and then he has a thick or hypertrophied lower lip. Apart from that, when you observe the gingiva, the anterior segment of the gingiva will be very dry. It is red and or erythematous, and then the patient can also have a little bit of bad breath. Okay, and then you can clearly demarcate between the exposed areas of the gingiva because of mouth breathing with that of the unexposed areas, which would be more moist, and then it is harmfully attributed to irritation from surface dehydration. Imagine the entire anterior area is exposed to the oral environment, therefore the lubrication or the cleansing property of the saliva is lost, and there will be some kind of a dryness or a dehydration in the tissues. Therefore these tissues are very much prone to develop injury. It can easily undergo injury. How do you manage it? First, you identify what is the cause of mouth breathing, and then you try to eliminate the cause, and then probably you can use certain oral screens in order to guide the patient or teach the patient how to breathe through the nose. And then coming to the next category of gingival enlargement, that is your drug-induced gingival enlargement. Now, in your drug-induced gingival enlargement, I told you the drugs which cause the gingival enlargement can further be categorized into your anticonvulsants, your immunosuppressants, and your calcium channel blockers. Now, if you see the list in the table, I've listed out the drugs, the anticonvulsants, the drugs which are causing your gingival enlargement, the calcium channel blockers, and the immunosuppressants. Of the anticonvulsants, your phenytoin and the valproic acid have been reported to cause increased amounts of gingival enlargement. Apart from that, your calcium channel blockers, especially your nifedipine, followed by your amlodipine, felodipine, and all the other calcium channel blockers have shown gingival enlargement, but maximum cases have been reported with a gingival enlargement associated with nifedipine and amlodipine and felodipine. Then the immunosuppressants, if you see the immunosuppressants, the two most important drugs are your cyclosporin and your tacrolimus. So the maximum percentage of, you know that your immunosuppressants are given in individuals who have undergone any kind of a transplant surgeries. So in order to prevent the graft rejection, these patients are put on an immunosuppressive therapy so that the body doesn't reject the graft by stimulating the host immunity and causing destruction of the graft. Therefore, these people are put on immunosuppressive therapy, and these mainly includes your cyclosporin and tacrolimus. And most of the cases reported for gingival enlargement were because of your cyclosporin. Let's see what is the histopathology. When you take a section of the people with the gingival enlargement induced by the drugs, most of the times if you see this kind of a gingival enlargement, you see maximum number of fibers. It's a kind of a fibrotic enlargement rather than an inflammatory, because there is a constant stimulation of the fibroblasts which will produce more and more amount of collagen fibers, therefore increasing the bulk of the connective tissue with lots of fibers. Okay, that's the most important feature. Now, what is the clinical features? Now, it is usually painless, and then until and unless it's secondarily inflamed or infected, but then usually it is painless and it produces like a bead-like enlargement starting at your interdental papilla. Sometimes it gives a typical shape of mulberry-shaped kind of a enlargement. What is the treatment for this drug-induced gingival enlargement? The first treatment is probably, you should think, if it is recurring even after repeated protocol, then probably you have to think of taking a physician's consent and then think of changing the drug, okay, or substituting the drug with another. And then you have to make sure that the patient is able to maintain oral hygiene, and maybe if the enlargement is too much, maybe you have to do a surgical correction by eliminating or by doing a surgery, that is your gingivectomy procedures. Now, the one important thing that I forgot to mention here is, in case of your cyclosporin-induced gingival enlargement, now this gingival enlargement is more vascular when compared to your phenytoin-induced gingival enlargement. That is the most important feature of your cyclosporin-induced gingival enlargement. Now, apart from that, if these drug-induced gingival enlargement, when they are secondarily inflamed because of the plaque accumulation, then secondarily they get inflamed, and then it can lead to the increase in the bulkiness. So what first you need to do is to do a thorough scaling and root planing, and then you wait for the inflammatory enlargement to subside, and then check for the actual drug-induced enlargement, that is the fibrotic enlargement, and decide or plan for a gingivectomy procedure. So the patient taking a drug, a patient is on a drug that can cause gingival enlargement, then what you have to do, categorize these patients and check if the patients on the anti-epileptic therapy, are these patients having gingival enlargement? If they are not having, then probably you do a thorough oral hygiene procedure, oral prophylaxis, and then you keep him on a periodic recall so that you can evaluate the gingival status in future if he might develop the enlargement. And then if he has the gingival enlargement, what do? You do again oral hygiene, maintenance, mouthwash, do a thorough scaling, root planing, and then a drug substitution, and probably you have to think of doing some gingivectomy procedure. Now, coming to the next category, that is the enlargement associated with systemic diseases or conditions. Now, you've categorized them into conditioned enlargement and then the others. The conditioned enlargement include the ones associated with hormones, that is your puberty induced or else pregnancy or menstrual cycle. Okay, now these are the ones. Let's see each one in detail. Puberty-induced gingival enlargement. What are the clinical features? The features are same to that of your chronic inflammatory enlargement. It affects both men and women, but then it's more common in women, and then it appears in the areas of plaque accumulation. Okay, first it involves your marginal and your incidental papilla, and then the facial side is most commonly involved. The enlargement undergoes spontaneous reduction once you have removed or eliminated your local factors, but it does not disappear. Increase in Capnocytophaga species and Prevotella intermedia have been noted. Treatment: educate the parent, and the education of the parent is one of the important part of your periodontal therapy, and then you do a preventive care. If it is mild gingivitis, then you can do just scaling and root planing. If it is severe, then probably you have to put him or her on an antimicrobial mouthwash, or do a microbial culture, and then local site therapy, or that is your local drug delivery, or an antibiotic systemic therapy, and then do probably a surgical removal of your excess gingival tissues. That is your gingivectomy. Coming to the pregnancy-induced gingival enlargement, and the pregnancy-induced gingival enlargement mainly occurs because of the excessive amounts of the two hormones, that is your estrogen and progesterone, within the body during pregnancy. You know, during pregnancy that these two hormones attain a peak level of probably 4 to 5 times greater than the normal levels that are present in a non-pregnant women. Now, these hormones have the capacity to increase the vascular permeability, and then they cause about release of lots of inflammatory mediators, and therefore they can cause, or they can be associated with lots of gingival enlargement. The marginal, so it can either affect the marginal gingiva, or this results from the aggravation of previous inflammation. The incidence of marginal enlargement has been reported to about 30 to 100%, means the entire all the marginal tissue is involved with the enlargement. So it's basically a generalized enlargement, and then the enlarged gingiva is bright red, or it can be magenta. It's soft and brittle in consistency. It is smooth and shiny. And then if you see the pyogenic granuloma, or the pregnancy tumor, now this is basically a localized localized pregnancy-induced enlargement. It is seen in just about 1.8% to 5% of pregnant women. Its predilection is most common in the maxilla, particularly in the anterior vestibular aspect. Now, if this is hampering, how does it look? First, let's complete. How does it look? It's basically a discrete mushroom-like enlargement, and then it's flattened spherical mass. It protrudes from the marginal or the interdental space, and then it's fiery red in color and often covered with small fibrin spots, and rarely it is larger than 2 centimeters. So it is most of the times it is less than 2 centimeters in size. When you take a histopathology, what you see, you have a thickened epithelium, and then with prominent retipex and leukocyte infiltration. They consist of a central mass of connective tissue with numerous diffusely arranged, newly formed, engorged capillaries. Okay, and then there's moderately fibrous trauma with varying degrees of edema and inflammatory infiltrate. What do? The treatment, the first line of treatment should be emphasized on preventing gingival diseases before it occurs. So when you know the patient is gonna, if the patient comes to you, so they have to go for a counseling before a dental counseling before they can plan for a family. So you have to counsel the patients, telling the ill effects of, or the betterment of maintaining the oral hygiene and getting a prophylaxis and a treatment done much before they can go ahead with family planning. And once the enlargement is already developed, how do you treat it? You think whether it is important. Is it hampering the functioning of the patient in chewing food or in having anything? Then probably the second trimester would be the safest period to excise it. If not, you can wait till the delivery is over. Now, enlargement in case of vitamin C deficiency, you know vitamin C deficiency is what is called as scurvy, and then vitamin C is also referred to as a ascorbic acid, and it is a water-soluble vitamin. Now, alone, it does not cause any periodontal destruction. Malnutrition associated alcoholism may predispose to scurvy. Low levels influence the collagen metabolism. You know vitamin C is very important in collagen synthesis. So if there is lack of vitamin C, then there is lack of collagen synthesis. So your blood vessels also have collagen, your gingival connective tissue has, your periodontal ligament fibers, your alveolar bone, cementum, all of them have collagen. So if there is a defect in or if there is a decrease in the synthesis of collagen, maturation and synthesis, then all these tissues will become more fragile. So they can be easily broken down. How is the histopathology? Inflammatory infiltration with a superficial acute response, scattered areas of hemorrhage with engorged capillaries, collagen degeneration and scarcity of collagen fibrils and fibroblasts. How does it appear clinically? It's uncommon in the developed countries. It may occur in infants or older people. The enlargement is usually marginal, and then the gingiva is bluish red. It can be friable, I told you, because of the fragility of the tissues, because of the lack of synthesis of collagen. And then it has a smooth, shiny surface. And then hemorrhage occurring either spontaneously or on slight provocation. Surface necrosis with pseudomembrane formation can be seen. How do you treat it? You give mega doses of ascorbic acid, that is about 18 grams per day, or 300 times of that of the recommended daily allowance. Coming to plasma cell gingivitis. Now, plasma cell gingivitis occurs, it's an atypical form of gingivitis that results because of some kind of a allergen present in any kind of the toothpaste, or basically it's a erythematous hypersensitive reaction. Okay, it is basically allergic in origin. Now, these can be the allergic sources can be from the chewing gum, dentifrices, or any other dietary components. The gingiva will appear bright red, and then it becomes again friable, and it's often granular in nature. It does not induce any loss of attachment associated with cheilitis and even glossitis. Histopathology, the epithelium shows spongiosis and infiltration, signs of damage of lower spinous and even basal layers. There's a dense infiltration of connective tissue with your plasma cells. Okay, the treatment is elimination. First, you identify what is the allergen and try to avoid the allergen, and then first is the lesions. After the identification, you avoid the source and then do a thorough scaling and root planing, and then the inflammation will subside. What is idiopathic gingival enlargement? Now, your idiopathic kind of a gingival enlargement has various synonyms. It's also called as your gingivostomatitis. It's called as elephantiasis. It's called as idiofibromatosis, hereditary gingival hyperplasia, and even congenital familial fibromatosis. What happens? Mainly it affects your attached gingiva, and then it goes on to include your interdental gingiva and your marginal gingiva. Sometimes it can even cover the entire crown. Okay, most common sites are the mandible, facial and lingual surfaces. The enlarged gingiva is usually pink and it is more firm and leathery. Okay, and the consistency is pebbled surface. It's a rare condition of unknown cause. The etiology is, they say it's hereditary, but we don't know the exact etiology behind it. Sometimes it can have a recessive pattern of inheritance. Enlargement begins with the eruption of teeth and may regress after extraction. The histopathology, when you take, you have bulbous enlargement with an bulbous increase in the connective tissue. So your connective tissue bulk is going to increase with a lot of fibroblasts and collagen fibers. Usually it looks avascular and consists of densely arranged collagen fibers more than your blood vessels. And then the surface epithelium is thickened, it's acanthotic, and you have deepened retipex. Treatment is surgical removal is the best mode of treatment for these patients. Systemic diseases causing gingival enlargement, like your leukemia. You know, leukemia is a cancerous condition wherein there is a pathological increase in the number of WBCs greater than 1 lakh cells per cubic millimeter of blood. So it's basically a cancerous condition. Now, what happens here is you can have an acute leukemia or you can have a chronic leukemia. In both the ways, you have your blast cells which are hypersynthesized because there is an excessive synthesis of your WBCs, and then all these WBCs try to exit out of the blood vessels, and then your bone marrow tries to produce. So before they can get mature, before the WBCs can mature, the immature forms are out into the blood. Okay, now because of the increased demand of the synthesis of the WBCs, your RBCs and your platelet counts are falling down. Okay, it's a very painful condition. The histopathology is the epithelium may be thinned or it may be hyperplastic. Cellular accumulation is denser in the entire reticular connective tissue. The blood vessels are distended and they contain predominantly leukocytes and RBCs, scattered foci of plasma cells and lymphocytes with edema and degeneration, an isolated surface of an acute necrotizing inflammation with pseudomembrane meshwork of fibrin. Coming to the granulomatous diseases, which includes one of the most important, that is your Wegener's granulomatosis. You know, granulomatous infections are chronic infections. Okay, they're characterized by acute granulomatous necrotizing lesions of your respiratory tract, including your nasal and oral defect. Oral mucosal ulceration, gingival enlargement, abnormal tooth mobility, exfoliation of the teeth, and delayed healing response. Okay, there is a granulomatous papillary enlargement with a reddish purple, and this enlargement which bleeds. So the most common etiology is the etiology is unknown, so we don't know the exact etiology, but then they have told that there can be some abnormal immunological response which is leading to this kind of a gingival infection. Histopathology, the epithelium is thin and acanthotic, scattered giant cells and foci of acute inflammation. The clinical features include they occur at any age and majority of the cases during the fourth decade of life or fourth to fifth decade of life. Slight predilection for the occurrence in males, and then it can produce a multi-system disease. Okay, and the treatment would be high doses of cortisone and then immunosuppressive drugs. And the next one of the granulomatous diseases is your sarcoidosis. This is a chronic multisystem disease of unknown etiology. Formation of non-caseating granulomas in one or multiple organs and tissues. Okay, it starts in an individual between 20 to 30 years of age, and then it is more common in the blacks, and then gingival enlargement may be smooth and painless. Okay, the histopathology, if you see, the granulomas consist of discrete non-caseating whorls of epithelioid cells and multinucleated foreign body type of giant cells with peripheral mononuclear cells. The other one is your Crohn's disease. This was first described in 1932. It may involve any part of the gingiva, whereas there is a constant inflammation or a chronic inflammation of the GI tract from mouth till the anus. It's common in young and it can be hereditary, and it has an increased susceptibility, or it can run in families. Now, diffuse enlargement of the lips can be seen, diffuse facial swellings, hyperplastic erythematous gingival enlargement. Histopath feature is epithelium may be normal or it can be hyperplastic, ulcerated, and then non-specific aggregation of lymphocytes and perivascular infiltrates of inflammatory cells. Treatment would be often treated with cyclosporin, which is an immunosuppressive drug, and corticosteroids. Coming to the tumors of the gingiva, first would be your epulis. Now, this epulis is a generic term which is designated to all kind of tumors and tumor-like masses of the gingiva. Epulis basically refers to the inflammatory rather than a neoplastic kind of a enlargement. Now, the reasons can be a reactive process of periodontal soft tissues, or a benign neoplasm of the periodontal soft tissues, or a malignant neoplasm of your periodontal soft tissues. Now, let's see what is the non-specific conditioned enlargements, that is also called as your pyogenic granuloma. It's a tumor-like gingival enlargement which is considered an exaggerated response to some kind of a minor trauma. Discrete spherical tumor-like mass with a pedunculated attachment to a flattened enlargement with a broad base, and then it appears as bright red or purple in color, and then the tissue would be more friable and firm. Maybe a surface ulceration can be present. The treatment would be elimination of the irritating local factors and surgical removal of the lesion. When you take a histopath section and see that the mass of the granulation tissue will have a lot of chronic inflammatory cells and then endothelial proliferations, and epithelium would be atrophic. See fibroma, it appears as a polyp, okay, and then it is a non-odontogenic fibroma. It is mostly arising from your gingival connective tissue. It's like a growth. It either can occur from the gingival connective tissue or your periodontal connective tissue, ligament connective tissue, and then it's a slow-growing spherical tumor. It's a benign kind of a tumor. The histopath would include lots of collagen fibers, okay, sometimes inflammatory cells. Peripheral giant cell granuloma. Now, this is also called as peripheral reparative giant cell tumors. It arises incidentally or from the marginal or frequently from the labial surface and may be sessile or pedunculated, smooth outline mass to irregularly shaped, multilobulated in appearance. It's usually painless and it varies in size, okay, and it can involve single or several teeth. Usually it is firm or spongy in consistency, and then it is pink to deep red in color. It can be sometimes invasive and it can cause destruction of the underlying bone. If you see the histopathology, the epithelium is hyperplastic, followed by an ulceration at the base, and then the highly cellular lesion with increased number of fibroblasts and even endothelial cells. Okay, numerous foci of multinucleated giant cells and hemosiderin particles are seen in your connective tissue stroma. Chronic inflammatory areas are scattered throughout. What is the line of treatment? Is elimination of the irritant and surgical removal. If you see the benign neoplasm of the periodontal soft tissue, that is your papilloma, it's mainly caused by your HPV-6, that is human papilloma virus 6 and 11, which is commonly found. And the most important, it produces a solitary wart cauliflower-like lesion. You can see the papilloma, the histopath would be, it consists of finger-like projections of stratified epithelium with hyperkeratotic and accentral core of your fibrovascular connective tissue. The treatment of choice is surgical excision, including the base of the lesion. You should always remember that you remove the base of the lesion with a little bit of the normal healthy tissue so that it doesn't recur. Leukoplakia. Leukoplakia, you know, it is a white patch or a white lesion, okay, and when you try to rub off the lesion, it doesn't go, so it's not a pseudomembrane, and because it's a keratotic lesion. Causative factors can be tobacco, pan chewing, or because of Candida albicans, or your HPV-16, that is human papilloma virus 16 and 18. It produces a grayish white flattened scaly lesion to a thick irregular shaped keratinous plaque. If you take the histopathology and see a typical epithelial changes where can be mild, moderate and severe. Hyperkeratosis and acanthosis and dysplastic changes are also seen. What is a gingival cyst? Now your gingival cyst, it appears as a localized enlargement that involves your marginal and your attached gingiva. Apart from that, it occurs mostly in the mandibular canine and premolar areas, often on the lingual surface. It is painless, but with expansion, it may cause erosion of your surface of the alveolar bone. When you see a histopathology, it's a cavity basically lined by an epithelium, and then you have collection of some fluid without any localized areas of thickening. Treatment would be surgical removal. Coming to the malignant neoplasms of your periodontal tissues, the most important being the squamous cell carcinoma. You know, carcinoma meaning to say it's always epithelial in origin, and a sarcoma meaning to say the lesion is from the connective tissue origin. Now, if you see squamous cell carcinoma, the clinical features commonly seen in the older individuals, and then in the mandible it is more common, and in the posterior areas you find it like an exophytic growth, okay, or an irregular outgrowth. It appears as a nodular lesion, often with ulceration and surrounding leukoplakia. Rapidly, it involves the underlying bone because it is definitely a malignant neoplasm, so it will encroach on the underlying tissues. Pain is most can be seen, and loosening of the teeth is most common. Histopathology, you find islands and cords of malignant epithelial cells which are seen. So it's a cord-like arrangement of your epithelial cells with varying amounts of keratin pearls, and a strong inflammatory reaction can be seen. The treatment would be a wide excision of or radiotherapy supplemented with radiotherapy. So melanoma, it's a malignant melanotic tumor most commonly occurring in males over the age of 40 years, and the most common site which is involved is your palate. Okay, you see it as a black or brown lesions. The absence of symptoms may cause delay in diagnosis. Sometimes you have an irregular border and the ulcerations can also be seen. If you take a histopathology, you have abundance of atypical melanocytes at the basement membrane zone, and it tends to spread deeply into the connective tissue. It has a two growth phase, radial and vertical. So it either sprays out like this or it has a vertical spread. You see the Kaposi's sarcoma. Now, Kaposi's sarcoma is most often seen in a patient associated with AIDS or HIV, and it is mainly caused by your HHV-8 virus, that is human. It's mainly caused by your HHV-8 virus, which may play a role in the pathogenesis. There are 4 classic forms of the disease. You have your endemic, immunosuppressive, and your epidemic. Clinical forms, that is your classic, epidemic, and your classic, endemic, immunosuppressive, and your epidemic form of diseases. It's more commonly seen in the homosexual males. Palate and the gingiva most commonly affected. Lesions begin as small red or brown, red to purple macular lesions, which eventually become nodular. There can be an ulceration and bleeding and associated with pain, which can occur as the lesion progresses. Coming to the last part of the gingival enlargement, that is the false enlargement. Now, false enlargement is a result of an increase in the size of the underlying osseous or your dental tissues, meaning to say there is no exact enlargement of the gingiva, but because of an underlying enlargement of any of the hard tissues, it can represent as that there is an enlargement. So the underlying osseous lesions like your tori, exostosis, or probably the patient is having Paget's disease or its fibrous dysplasia, cherubism, and then central giant cell granuloma or ameloblastoma. So all these will represent as if the patient is having a kind of a gingival enlargement, but rather it is a underlying osseous deformity. Okay. Now, underlying dental deformities can be during various stages of tooth eruption. So you can have something called as an eruptive gingivitis. That's it. That would complete the entire topic on gingival enlargement. Thank you.